in effect, making the doctors smarter and better able to treat you. And additionally, a committee of doctors, patient advocates, and other experts who do not work for the government will help make recommendations about the medical benefits insurance plans should provide to protect the patients. So it's prohibited from being used to make any decisions on that matter, so that, you know, the whole rationing thing is.
Thank you, Congressman. I want to follow up on that. AARP has worked very hard on comparative effectiveness research, and we get a lot of calls from our members on this, and we work very closely on these provisions, along with many physician groups, the American Association of Family Practitioners, the American Medical Association, many other groups. The cardiologists feel very strongly about endorsing these provisions. Very strongly, because right now the only information physicians generally get are from the Federal Drug Administration that compares a drug simply to a placebo, that says whether or not a drug is better than just a sugar pill. And so doctors get very little information, for example, about whether back surgery is better than just resting, or whether or not you should have physical therapy, an example, or back surgery. We also get a lot of information doctors don't often know, comparing one treatment option to another. As I mentioned, I used to work at Kaiser Permanente, and they did a lot of comparative information about whether if you got a hip replacement, if one prosthetic device worked better than a certain prosthetic device. And they like to get that type of information so that they could say in a certain patient, would this work better? What's the recuperation rate? So that's simply what it's funding. It's not trying to make decisions on cost. It's trying to look at what's the effectiveness of certain types of treatment options and giving the patients and doctors that information so that they can compare treatment options and sit down with people and say, you may be out of work for 6 weeks if you have this surgery. You may be able to recuperate within 3 weeks if you have this surgery. We've done a number of tests and studies that help people decide the risk and facts, the risk and what they can consider, what the side effects of different things are. We think consumers want this information. That's what our members have told us. On your other question about medical loss ratios, I just want to be clear to folks that what this measures is how much insurance companies spend on administrative costs. This has come up a lot in various states. Typically what we find is most private insurance companies spend on average about 15% of their costs on administrative costs. This is what they spend to bill people on advertising, marketing, those types of things. What some places like California last year tried to do a huge insurance market. They tried to limit that to 15%. Some companies wanted to make it more like 25%. This is one provision, as Congressman Scott, that hasn't been in all bills. It's very controversial. As the gentleman mentioned, it's not something that people have decided on. AARP doesn't have a position, but I just wanted to be clear that's what we're discussing.
Yeah, that is in the bill. Where I understand it's in the bill.
We have to take a question from the
You
floor.
have no answers to it. You're putting it in the bill before it's even done.
Next question.
Please note that we do not have the final bill. Everything is a work in process. And, sir, by the very nature you've mentioned in this, is going to allow me to respond by making sure that we get and make sure that this loss ratio does what it is supposed to do. What we're trying to get, more than anything else, is greater efficiencies. And as she mentioned, there's a lot of overhead, there's a lot of administrative, there's a lot of waste and fraud and abuse going on in the system. So what we're trying to do is find mechanisms in various parts of this whole healthcare process where we can get savings. We can't be able to do that if we don't put some things in place at various points to see where we can get these efficiencies. And that's the whole purpose.
I agree with you, Congress, but let me ask you one last question.
Thank you, Frank. I'm sorry, we can't take any more questions. I'm sorry, sir. We can't take any more questions. Next question, please. Please be considerate. We only have about 30 minutes remaining. So a lot of people have to ask questions. So this is one question per person 2 minutes. Thank you. Next question.
Mr. Scott, my name is Lorraine Brown. I'm native in Georgia. I've never done this before, so I'm pretty nervous. I've sent you a lot of emails, though. One of the reasons our health insurance is so high is because we have been giving free health care to illegal aliens. They have crowded our emergency rooms with their routine health care at no cost to them. Hospitals, by law, cannot turn anyone away. HR 3200 does not require the inclusion of illegal aliens, but it does allow the inclusion. Any illegal alien willing to lie will get the plan because the plan does not provide for any verification or even require that a person be asked if they are legally in the U.S. Will you guarantee that illegals will have no loopholes to slip through in order to participate in our health care program?
We have done that. We have made sure that there's nothing in this bill, that this bill expressly prohibits any funds being used for illegal aliens, illegal immigrants. However, you did mention the problem area. It's just like others that don't have insurance. Illegal immigrants, or the 47 who don't, or the 14,600 we're losing every day. They're out there. And the only help they will get is at the emergency room. That's why we must move quickly to get this bill in place so that we can have a way of getting folks from having to depend on the emergency room, because illegal immigrants, that's their health care. We, like you say, we can't turn them away. So that's why we're trying to put this bill together, so that we can get people, and at the same time, as I said before, not provide any health care plans for illegal immigrants. But we can do nothing about the fact that we cannot turn them away at the emergency room. So, that's where they're going. That's where they will be, but they will not be getting it through this program.
It looks as if HR 3200 refers to ensuring minimum standards are met. This indicates to me only minimum standards need to be met. Minimum standards could certainly limit care choices. Who defines minimum standards and who can change minimum standards?
Okay. In the bill, we have and particularly with the local option, but the public option, it has what we call a bare bones minimum standard package of benefits. We have a group and a commission of physicians and experts who will determine basically what that is. And basically, it's what you have in the hospitalization, the doctor visits, the basic things that are needed for that minimum.
It can also limit care, deny care.
No. We expressly put in the bill that no care can be denied for a pre-existing condition.
But it can be limited. The care can be limited. The medication could be limited. The operation, the procedure could be limited.
Not under the plans in the bill, perhaps now. These are practices and reforms that we want to put in. For example, right now, you have the sky's the limit on your out-of-pocket. And that's what's taking people into bankruptcy, because there is no cap on out-of-pocket. This bill will put a cap on out-of-pocket. This bill will make sure insurance companies can't drop you when you get sick. This bill will make sure you're not denied insurance for a pre-existing condition. And that's another reason why we were having the physicians and the medical experts make sure we design that minimum package to take care of all of that. But there are no limits in the bill. As a matter of fact, the bill expands the limits and the services